Yes, sir.
KK, I think, has to run to a emergency in his unexpected emergency. So we'll go with now the rest of the original program. So Amar is going to share a case of a giant cell tumor. Amar, you can share
Yes,
your
sir.
screen.
Yes. Okay, sir.
Just for those who don't know him, Amar is practices in a so-called small place, Dahod, which is a district place. He's got a huge volume of work in terms of compound fractures, good principles of application for bifocal, trifocal, long lengthening, and he really kind of underlines the fact that even in smaller places, you can do excellent quality of work as long as you pay attention to the principles. You'll never hear him giving an excuse that, oh, I'm in a small place, therefore please accept a poor result. The results that he shows are always equivalent to anything which people in big cities show, and that is despite being in a smaller center in terms of infrastructure, patient being able to pay, etc. Go on, Amar.
Thank you, sir. Thank you, sir, for kind words, and thank you for giving me an opportunity to present in this forum. Uh, Today, I am presenting case of proximal tibia giant cell tumor with pathological fracture. This patient had grade 3 GCT and his age was 22 years and from low socioeconomic class. He was diagnosed since last 6 months. He took multiple opinions and was admitted at teaching institute for 3 weeks where his biopsy and MRI was done. Films are not available. He had cost concern for megaprocesses. Looking towards this radiological picture, it is not an amenable to treatment with intralesional curettage. So knee salvage was out of question. So there are only two options left. Either one can go for end block resection and megaprocesses or resection arthrodesis. Massive osteochondral allografts has availability issue, high rate of infection, and failure of allograft, non-union, and joint instability. Regarding end block resection and megaprosthesis, it is a primary modality of treatment for limb salvage in malignancy. It is preferred method in giant cell tumor. In benign condition, most patients likely to outlive the expected life of prosthesis. It has good short-term results, but most patients are not adequately counseled for prosthesis survival, revision, infection, etc. What are the issues with megaprocesses? Aseptic closing is most common complication. Possible factors are poor quality of cementing, increased torque at constrained hinges, and with greater resection of length. So larger the resection, chances of loosening are more. Abnormal peak stress with extensor leg, and most of patients are from younger age, and they have greater physical activity and body weight more than 68 kg is associated with 3 times higher rate of revision. Another thing is infection, which is mainly associated with duration of surgery and extensive exposure. All incidence ranges from 7% to 23%, and in some cities it is as high as 33%, and it is higher rate of infection associated with proximal tibial reconstruction as compared to distal femoral reconstruction. And in such cases where joint is infected post megaprocesses, salvage is very difficult and amputation is often required. Other issues are periprosthetic fracture, flap necrosis, amputation mostly due to infection, implant breakage of stem or hinges. Extensor leg is seen in almost all patients who are treated with megaprocesses in proximal tibial defect. It ranges from 10 degree to 35 degree. 5-year survival ranges from 58% to 79%, which is in uncemented. Morbidity in event of complication is too high and with added expenses of revision, fusion, amputation. These are two cases where I started my journey of segment transport in proximal tibial defect. One had broken prosthesis and other had infected tumor prosthesis. Other option of resection arthrodesis with nail means other option of resection arthrodesis with nail and fibula graft. Here, fibula takes too long to get fused. It requires prolonged protection in cast and vigorous activity in average time of fusion is around 1 year. Overall incidence of non-union are higher and residual shortening is likely. Resection arthrodesis with plate is of historical interest and I will not go in detail of this. Other option which seems very lucrative is transport over nail, resection arthrodesis with nail and ring fixator. Here, usually single corticotomy is done, which saves time in frame and prevents deformity. Residual shortening is minimal, non-union rate is low, chances of refracture are minimal, and if foot frame is incorporated, chances of equinus are less. The only caveat with this method is if the spintract infection or dissection site gets infected, then salvage is very complicated and patient may end up in amputation. Segment transport and dissection arthrodesis, there are many advantages. It's provide excellent stability, least soft tissue complication, and with dual corticotomy, one can reduce time in frame in less than 1 year, and one can prevent equinus by incorporating foot in frame. Disadvantages are segment transport related morbidity, chances of refracture post frame removal, and docking site non-union. This is how I did my preoperative planning. I kept 3 rings in femur, 3 rings in tibia, and 1 in foot to prevent equinus, and corticotomy to be done between second and third ring distal femur and distal tibial corticotomy between fourth and fifth ring. After detailed counseling, I convinced patient for resection arthrodesis. He was given option of both megaprosthesis versus resection arthrodesis. He took 6 weeks to decide and opted for resection arthrodesis. It was post-resection gap was around 11.5 centimeter, and this is his images post-resection. I did distal femoral and distal tibial corticotomy at 2 weeks, and these are images during transport. One can see that this femur is getting transported distally and tibia part is getting transported proximally. Pre-docking images where in such cases when we do a large transport, one can expect some amount of skin invasion, and that's why open docking is essential. Pre-docking radiographs and radiographs at the time of docking. It took around 2.5 months for patient to reach a docking stage. Open docking was done, skin invasion was removed, and there was no bone graft was not kept. Post docking, he was allowed to work full weight bearing, and these are images at 6 months where one can see that regenerate consolidation is going on in distal femur corticotomy, proximal tibial corticotomy, and knee fusion site is also consolidating. This is gait at 6 months where one can see that he is walking unaided, and at 6 months I had removed foot frame because after that there is less likely of developing equinus. Sorry. These are at 9 months I removed frame, and these are images post frame removal where one can see that whole regenerate consolidation is in good and union is good. Still, I protected it for around 3 months. 1 week post frame removal, I applied him cast, and I protected for a period of 3 months. At 12 months, these are images post cast removal, and this is no limb length discrepancy and clinical picture, and he walks unaided without any issues. Sorry. So, sorry. Ultimately, his new fused external fixation index was less than 1 month. It was at 22.7 days per centimeter. He had no pin tract issue, and index procedure done was of major magnitude, while rest of procedure were of minor magnitude. He had no problem, obstacle, or complication, no shortening, no deformity. Flap cover was not required, bone grafting was not done, and patient was ambulatory during whole course of treatment. This treatment is cost effective, no need for revision for surgery in future, and patient is extremely satisfied with outcome. So take home message is adequate counseling is must. Whenever such patient comes for me in for treatment, I always give them option of mega prosthesis versus fusion and give them adequate time to decide. And some of may consider this as a viable option. I consider this as a preferred alternative as far as proximal tibial defect reconstruction is considered. Focus on adequate stability of frame, prevent angulation, prevent equinus, and address docking site issues to prevent non-union at docking site. Thank you, sir. Thank you. Thank you all.
Thank you, Amar.
Yes, sir.
So
Should I stop
kind
sharing?
of, yeah, go on.
Should I stop sharing screen?
No, let it be in case we need to just go back to any of the
Okay, sir.
X-rays.
Yes, sir.
So essentially, bone defect due to any cause, you can use the Lizarov as a good technique for replacing bone which has been lost either from excision. And we always say that excision of infected bone has to be oncologic. And this is again in oncology, the amount of bone that you want to excise does not need to be restricted. You can go with all the safe margins, etc., that you want, so that there's no risk in terms of the oncology side. Let me ask you, Amar,
Yes, sir.
have you also dealt with any malignant tumors like this?
So, sir, I have treated complication of patients who are treated with mega prosthesis for malignant tumor. Both cases which are shown initially in one slide were treated for osteosarcoma. One had broken hinge and another had gross infection post mega prosthesis.
Right. So that is the point there is that for malignant tumors, I think today the overall treatment for malignant tumors is a holistic treatment in terms of chemotherapy, excision, and all of that. So that is best left to the tumor surgeons. And there are now, I think, a good number of tumor surgeons who will treat these patients with the proper principles all over the country. I know Gujarat has got quite a few. Mumbai and Maharashtra also, Mumbai, Pune have good oncosurgeons. So the principle there is that you allow them to do whatever is the oncological treatment. And unfortunately, I think some of them or many of them may not necessarily be amenable, or they may not agree with using the Lizarov for treatment of the defect, and they will try and do a mega prosthesis. But the points you raised in relation to a mega prosthesis are very, very important, even in an urban setting. That the revision rates are much higher, risk of infection, etc., is higher. Even if they have excellent infrastructure, infection doesn't happen in the hospital, but 3 years, 4 years later, a carious tooth or urinary infection, infection spreading from the bloodstream is always there. And for a person to have a solid leg to walk on is a good idea. Vasu, your thoughts?
Yeah, because Lizarov is when it has any gaps, you can fill it up. The only thing is, even in osteosarcoma, whatever things, let the primary treatment be done by the oncologists, oncosurgeons, and the defect can be very well managed by us. It's not a big issue. But in your case, I think when you do an excision of the upper end of the tibia, probably I think I will remove the distal and femur also together with it. So you are retained the distal condyle there. So do you had any problems of docking?
Sir, at the time of docking, I refashioned cartilage of distal end of femur.
Yes. So what I do now, I remove the distal end also along with that.
Okay, sir.
And we can take some part of the condyles and make little narrow there so that the lengthening or transport is easier. So both condyles can be given a little bit posterior part when both medial and lateral part, because you don't need that much of a big bone for healing. You can take that bone as it's a good graft there in the distal femur.
Okay, sir.
You can use it around that area. And another issue is while docking, remember about the anatomical axis. You're perfectly aligned to the anatomical axis of the femur.
Mm-hmm.
Normally, the femur mechanical and anatomical axis are 6 degrees different.
Mm-hmm.
So at the end of it, you must get 6-degree valgus at the docking. It should not be perfectly aligned. It has to be 6-degree valgus in the tibiofemoral angle. That looks a little more and that improves the hip function. See that X-ray?
Sir, you can see this scanogram. Overall, HK axes are well aligned.
No. You see the right side, you can see a little bit valgus at the knee joint.
Yes, sir.
Anatomical axis and mechanical axis.
Yes, sir.
Here it is straight. See, if you keep, begin, what will happen now is there will be 6-degree adduction in the hip joint. So you can get a little more.
This is central, and this one is a little bit of coming onto the medial side of the femur. This doesn't matter in terms of the knee, but what he's pointing out is that the hip will tend to be in a little bit of, relatively speaking, varus. The moment you get mechanical axis varus in the knee, the hip tends to be in a little bit of varus.
No, you got 99%. What I'm making is try to make 100%.
Okay, sir. Thank you, sir.
Just go back one X-ray. There are a couple of questions on the close-up of the non-union side.
This one?
Yeah. That's good. So here on this, there are a couple of questions that 2-3 people have asked. Krishna Kumar has asked, then somebody else, Puneet Pai has asked question that is there a problem with or possibility of problem with the common peroneal nerve palsy because the fibula is subluxed posteriorly relative to the femur. Amar?
No, sir. No, sir. It's in slow transport. It's unlikely.
And you have not done any.
Nothing. I have not released the peroneal nerve, and neither I have decompressed it.
So if anything, actually, it will get a little relaxed, I think. So the likelihood of a peroneal nerve palsy is not very much. So
overall, we are not lengthening the limb length. Basically,
exactly.
Transporting. So now is not getting stretched.
Yeah. And Dr. Anwar Hussain has a question. You denuded cartilages from the distal femur at docking time at the site. So answer to that you had already given.
At the time of docking, distal femur articular cartilage needs to be denuded.
Jijesh has a question. How do you transport both fragments together? Go back to your frame.
Yes, sir. Sir, one can see here that femur rods are getting distracted and tibia rods are getting distracted. So basically, this is a converging trifocal osteosynthesis where both transported fragments will converge towards each other.
Yeah. So you've got this is
far off transport.
This is fixed, and this ring is moving up.
This ring is moving down, and this ring is moving up.
Moving up. Okay.
Third ring is moving down, and fourth ring is moving up.
Okay. And then that means you are moving the nuts at 2 places, one here and one here. So that's
3 places.
It is compressing also.
Yes, sir. Quarter ton dissection at distal femur corticotomy, quarter ton dissection at distal tibial corticotomy, and half ton compression at docking site daily.
At this one.
Yes.
Correct. Okay.
Yes, sir.
Yeah. So great. So that answers a lot of the questions on how you do it. Obviously, the result has shown. Divya has raised his hand. Yeah, Divya, what do you want to ask?
So at the time of docking, the fibula was left floating again, or was an attempt made to get it to the femur and fuse it with it, like a bipillar sort of?
No, fibula was not touched. It was left as such.
Okay. But what if you get the fibula in contact with the distal femur? Wouldn't that lead to a sort of better healing on both the pillars?
So generally, fibula doesn't come in way of transport either of distal fragment or proximal fragment, and it's better to leave it as such. It will reside little above the distal femur articular surface post docking.
Okay. Yeah, but his question was, I think, whether if you incorporate the fibula also there to the distal femur, you will have 2 points of healing, maybe a better quality of healing.
Both are in different plane. Fibula is way posterior, and it is very difficult to bring it to in a line of femur.
Okay, right. That is also
No,
true. If you just move it up, it's
Mangal, in
mostly.
that case,
You can see
Yeah.
here.
Mangal, in that case,
Yes.
if the fibula is united to the lateral femur condyle, then our precision of the tibial correction should be little more perfect.
Yeah.
Now you don't have to worry about that length disparity between the fibula and the tibia.
With
So
this.
it is not healed. So you don't have to worry. Otherwise, the ankle joint, there will be extra strain.
Okay.
Now
Fair
our
enough.
headache is actually less when the fibula is not healed. Yeah.
Okay. So we don't bother about the fibula.
Okay, sir.
Great.
Sir,
So
I would like to
thank you.
ask a question.
Yeah.
Sir,
Dijesh?
what about patella whether you remove or I can see on
No,
this?
sir. Patella is there. Patella, you can see in this image, patella is there, and extensor means patellar tendon gets attached to this distal fragment once you dock it.
Okay.
And basically, patient walks with fused limbs. So quadriceps doesn't make much help as compared to what is in resection arthrodesis.
Yeah.
Can you use this patella for the grafting in the same time docking?
One can use it. One can use it.
Okay.
Great. Thank you. Thank you, Amar. You can
Thank you,
stop sharing now.
Okay, sir.
And next, Dijesh.
Yeah.
Dijesh has a case today of neuropathic ankle joint, isn't it?
Yes, sir. Yes, sir. Can I start?